Good afternoon, everyone. It's great to see you all. I'm really excited to kick off our Sam Regenstrief Distinguished Lecture Series, and we have a visitor who's been here many times before. Chuck Friedman is here joining from the University of Michigan. So Dr. Friedman he's a professor of learning health systems at the medical school at the University of Michigan and the former founding department chair in the Department of Learning Health Sciences. He joined the University of Michigan in 2011 as a professor of information and public health and director of the Michigan Health Informatics Program. He has a very long CV. I'll just mention a couple of things to highlight. He back in 2007 to 2009 was the Deputy National Coordinator, the Office of the National Coordinator for Health IT. And then from 2009 to 2011 is ONC's Chief Scientific Officer. So he has done an incredible amount of work, and we are really excited to have him here today. We had a great time at dinner last night, and then we're chatting all about learning health systems, which is an important strategic priority for us at the Institute, and all of the successes he's had in this area. So I don't want to take up any more of his time, and please give me a round of applause to welcome Chuck here today. Thank you.
Try out the clicker here. So we'll be fine. It's okay. Yeah, it's okay. Well. So the grant. Oh, what did you do? All right. Okay. So here is the institutional disclosure statement. And I will add a disclosure statement of my own that I am the board chair of a not-for-profit called the Learning Health Community, which is engaged in many of the same pursuits as what I do at the university. So it's very important to keep that distinction clear. So I'm going to talk about AI, and I'm going to talk about learning health systems. And I have become convinced that these two ideas are very much enmeshed with one another. And it's one thing to say that they are enmeshed, and no one will disagree with that. I'm going to talk about how they are enmeshed and how, by virtue of understanding the enmeshment of them at a deeper level, we might be able to take maximum advantage of the fact that they relate to each other, and if you believe me, actually need each other in order to be fully successful and realize what I consider to be their transformational potential. So I'm going to start with a personal story that actually relates to my work at the ONC, so I'm glad Rachel mentioned that. Then I'm going to talk a little bit about what I think a learning health system is, what makes learning health systems distinctive from other health improvement models or approaches. And then I'm going to talk very briefly, going out on a limb, and offer some ideas why learning health systems may succeed in having a transformational effect on health and healthcare where others have failed. They've done good, but have not had the transformational effect that everyone had hoped they would have, myself included. Then I will get to my main point. It'll take a while, but I'll finally get there. Introducing AI in its relationship to learning health systems, explaining why they need each other, and outlining what a fully AI-enabled learning health system would look like as a realization of this enmeshment. So that's the plan. So I'm going to begin with a story, and of course, all stories begin with once upon a time. So once upon a time, as Rachel mentioned, I was the deputy director and later CSO of what's called the ONC. I was there for 4 years. I came in there with a full head of dark hair and came out looking like this. But, you know, it was worth it. we all have to make sacrifices. So in 2007, we witnessed the birth of the idea of a learning health system, and this came forward from the Institute of Medicine, now called the National Academy of Medicine. They put this forward in a report of a workshop that took place in 2006. So that's the origin of the idea. And then in 2009, as some of you will remember, it's now been 16 years ago, following the Great Recession, Congress passed the so-called Recovery Act, $787 billion. And within the Recovery Act were funds appropriated to promote adoption and so-called meaningful use of EHRs, and there is President Obama signing the Recovery Act. Well, soon thereafter, David Blumenthal, the very able, politically appointed national coordinator, went on the road, because that's what people at his level do, telling people that meaningful use of EHRs to promote the program would create a learning health system. So what happened next? Sitting at my desk, minding my own business, and my phone rang, and that's when you still had a hardwired phone on your desk, and I picked up the phone, and it was a cold call from a staff member at the IOM. And she said, hey, your boss is going around telling people publicly that EHRs will create a learning health system. Do you agree with that? And I would have said no, whether I meant it or not, but I meant it. I said, of course not. So she said, basically, tell him to shut up. And I said, well, that's not what we do in the government. You don't walk into the office of your boss, who happens to be a presidential political appointee, and tell him to shut up, but I'll do my best. So I went home and thought about how I was going to handle this situation, and then I got an idea. So they lived happily ever after. And here's how. So I went in to talk to David, and I said, well, we need to be clearer, David, about the relationship between EHR meaningful use and learning health systems. I think the former may be necessary, but is certainly not sufficient for the latter. And he said, to my great relief, notice how I avoided telling him to shut up. And he said, to my great relief, this is what you learn to do in the government. He said, I agree. I'll be clearer about that. And I went on and just went a little bit further because he was so responsive. And I said, well, the LHS is the big end goal here. And as your chief science officer, I think because it's the big end goal, I'd like to make the learning health system into a campaign for our office. And he said, to my great relief, of course. And from there on, I spent about 50% of my time for the 1.5+ years that I was still there, and he was still there, promoting learning health systems in the way you could from the government perch. And we wrote an article which appeared in Science Translational Medicine on what a national scale learning health system might look like. So we all lived happily ever after. But there's a moral to this story, because in addition to starting with once upon a time, if you tell a story, you have to say they all lived happily ever after at the end, and then you give them the moral. So here's the moral of this story. The moral of the story is you got to separate the means and the ends. And what I was able to establish is that EHRs are a means and learning health systems are the end. The other part of the moral is you certainly don't want to invert them. Sociologists call this a means-ends inversion. That happens very often in the world. So let's not get this confused. Moving ahead, 15 years or maybe more, I think this applies to AI in the same way. I have no doubt that contemporary AI is a game changer. in its own ways. But we need to keep our eyes on the fact that it's still a means and not an end. And in this talk, I'm going to frame learning health systems as the big end goal, with AI in a key, very important contributory role. So while AI and LHS need each other, the relationship isn't completely symmetrical. So what are learning health systems? There are a lot of ways to think about it. The IOM, now the NAM, has a very long, convoluted definition of a learning health system. I actually challenged my colleagues who know English better than I do to try to diagram the sentence. It's one big, long sentence, and none of them were able to diagram it. So inspired by that, I came up with a shorter definition that I will share with you, and that is that a health system of any size, at any level of scale, becomes a learning health system when it acquires a capability, and the capability is to continuously and routinely improve health by marrying discovery to implementation. And the key word in that shorter definition is marrying. The relationship, it's a bit metaphorical, but I think the metaphor holds. Now, where can you read more about learning health systems? You certainly can read the 15 or so books and monographs that have been published by the IOM/NAM since that original publication in 2007, and they're all available at this URL. And if you're going to distribute the slides, the URL will be available to click on. And I will now turn to the shameless commerce part of this talk. You can read the journal creatively titled Learning Health Systems. We thought long and hard about that. And that journal is an open source journal and is now in its 9th year of publication. And I'm very proud that it has grown dramatically in impact to the point where in 2024, there were 142,000 full text downloads of articles from this journal, and you can see the increase. Let me ask, any of you geeks out there, can you account for the dip? And it isn't the pandemic. Come on, there are lots of geeks here. Surely you'll. It was bots. Wiley got wind of the fact, and we were tipped off by the distribution of countries from which the downloads were coming, that a lot of the downloads were probably from bots. So they found a way to filter out the bots, and that's why it actually went down, but it went back up again. Okay, so another feature of learning health systems is that they can exist at any level of scale. And one of the system features of a learning health system is that at any level of scale, they're self-similar across levels of scale, whether the system is a single organization, a network of organizations, a jurisdictionally defined system like the Indiana Learning Health System concept, national in Switzerland, or even global, which we don't have yet, obviously. They function in pretty much the same way, despite their level of scale. Okay, so how do learning health systems improve things? And this is not a new idea. This has been around for more than a century. The notion of cyclical improvement processes. And what you see here is that learning health systems improve by marrying discovery and implementation through complete cycles. And just to say a little bit more about how this process works, in a learning health system implementation or incarnation of a complete improvement cycle, the process begins down there at 5 o'clock with the formation of a multi-stakeholder community that shares a passion to solve a problem, a significant problem of interest to that community, and such a level of interest that it induces passion in that community to solve the problem. That begins a part of the cycle where practice is captured as data, because you really can't learn without data. The data are assembled as you enter the discovery phase. The data are analyzed, and what that does is create new knowledge or evidence that is specific to the setting in which this learning community is operating. Then, because any problem of that nature, a passion-inducing problem, is going to have been studied by others, at this point in the cycle, external evidence is brought together with the so-called internal evidence, and the results are then by the community interpreted, and a deliberation occurs over what to do with what we learn. And the cycle is complete in the sense that the community then moves directly into designing one or more interventions. Now in the implementation side, action is taken to actually implement these interventions, and then cycling around to the second iteration of the cycle. The system has changed. The new practice is captured as data. It is determined whether things have improved or not, and where things may have improved in certain places, what aspects of the intervention were related to that improvement. This generates a whole new set of data, and the cycle continues. Just to give you an example, I'll share with you work we have been doing on a very, very nasty problem of out-of-hospital cardiac arrest. Does anybody know what the mortality rate from out-of-hospital cardiac arrests are? Yeah? Pardon me? Well, it's a little better than that. Yeah, it's about 10%. And it's 8% in Michigan, so there's not even at the level of the national average. So there was great interest in forming a learning community to try to increase the survival rate from out-of-hospital cardiac arrest. A community came together, and this was a wonderfully diverse community from first responders, firemen, police, and paramedics, and ED docs, and cardiologists, and researchers in the field, and survivors, all too few, and family members of non-survivors, all too many. And this community came together and collected or assembled a wide variety of data to learn from. These were assembled into analytical data sets, qualitative and quantitative analyses as appropriate to the kind of data were undertaken. The vast external evidence, none of which to date had really improved things very much, except in certain areas like King County in Washington State. The community executed a process called deliberative dialogue to begin to think about what to do. And lo and behold, a completely novel idea emerged from this that, believe it or not, no one had yet thought of. And the idea was because, and we had firemen there. And if we didn't have the firemen there, it's very likely that this idea would not have emerged. Somebody said, we have fire-safe homes. Why don't we have heart-safe homes, where just like homes have fire plans, have a plan of what to do if someone has a cardiac arrest in the house. 72% of cardiac arrests that occur out of hospital occur at home, which makes sense when you think about it. So we have designed a heart-safe home initiative. The American Heart Association is so interested in this, they want to co-brand it. And we are now in the process of implementing the Heart Safe Home initiative. It's a major undertaking, and we're in the middle of that now in a region And there are many ways that we're going to promote homes having heart-safe plans, heart-safe home plans. So this is the learning health system in action against a very, very wicked, I can't think of a more wicked system problem. So just coming to the end of this first part of the presentation, I just want to hammer home the point that better health requires this marriage of discovery and implementation. And not just this, which is what I and probably many of us in this room have built our careers on doing. Collecting data, analyzing it to create a model or a result, publishing that in the journal, and then thinking there's somebody hanging around just waiting for that article and to do something with it, going on and short-circuiting the process, collecting more data, publishing another paper, and so on and so forth. And I think we all know too often there's nobody home to do anything with that paper. And when it happens slowly. And I'm of the belief that this is what largely accounts for the 17 plus or minus year latency between the generation of new evidence that can improve health and its widespread application and care. Now, to the point of this talk, there's another thing that a learning health system is not, and that's a cycle with a gap at the top. The gap at the top is really pernicious. Very often this discovery process continues, there's new evidence generated, everybody's excited, but then you get to that point at the top. Think about it like you're on a roller coaster and you get to the top of the roller coaster and there's a gap in the track. How are we going to get across that? And this happens too often. So you just publish the results in a paper and you go off, and nothing directly related to the work of the community that generated the new evidence is done. So I'm going to come back to this. So what makes learning health systems distinctive and why they may succeed where others have failed? I would argue there are three very distinctive and important features, and there's an article in Learning Health Systems about this. One is this idea of embraced uncertainty. Another is this idea of continuity. And the other is the fact that the learning health systems are truly systems and have a lot of the resilience that systems have. Embracing uncertainty means that the process starts at 5 o'clock, beginning with capturing practices data. And this requires the community to acknowledge that they don't have the slightest idea what the intervention is going to be. Collectively, every member might have a hunch, but collectively, the community is not committed at this point and is open to whatever the evidence suggests. This contrasts with what happens all too often. The community comes together and some members of the community who have a certain amount of power or authority or pervasiveness say, we can skip all that stuff. I know what we should do, X, whatever X is. And effectively, that means the cycle starts at 12 o'clock with implementation. And that could work if by some chance those influential people are right. But one of the problems is if you skip that discovery step, the community as a whole is not committed to whatever is discovered, and that can cause the gap at the top, and we don't want that to happen. The second is continuity, that the community that discovers is also the community that implements. I said this learning community follows the whole process around, and in other words, it goes from the green to the blue to the red, sort of changing color, but it's the same basic community that executes this cycle. They can bring in expertise to help them at the different stages of the cycle, because you can't expect a community to have all of this expertise within its own members. But there is a continuity, there is a continuous persistent presence throughout the cycle from this community. And not this, which is a problem many institutions have, many organizations have, when they try to function as learning health systems. They say, okay, yeah, we're going to try to do these cycles, but the problem is the people at the organization who would do these things are in different subparts of the organization. So you might have the program analysts who would do the green stuff, the health services researchers, and I've got nothing against them, but they do their piece, and then the change implementers who do their piece. And each of these sub-organizations will have its own leadership, its own culture, and probably their own priorities. And if you have to have handoffs from one of these to another, I've got to use a football analogy in the Big Ten, so they're going to be fumbles. And that's not a good thing, and the cycles won't be complete. And the third is infrastructure. And I'm going to dwell on this a little bit because this really connects learning health systems with AI. If you just have a bunch of these improvement cycles going on and every one of them is a tub on its own bottom, that's a non-infrastructural approach. It's like saying if you have a city like London that's bisected by a river and you want to get lots and lots of people across the river every day, there are two ways to do it. You can have an anti-infrastructural approach and say, okay, folks, build yourself a rowboat and row yourself across. We may even give you some wood and glue and nails to make your own rowboat, but the only way you're going to get across is by building your own boat and rowing yourself across. Or alternatively, we can implement an infrastructure, and the key piece of infrastructure here would be a bridge. What's the analogy for learning health systems? How do we enable a large set of these improvement cycles, each being conducted by its own community and addressing a unique problem, to function as a scalable and sustainable system? Well, this is kind of a weird figure. We call it the tornado diagram, but it looks like this. You have the idea of multiple simultaneously occurring cycles seen at the top of the figure. Underneath it, you place a socio-technical infrastructure, which provides services, and it's socio-technical because it doesn't just consist of technology. It consists of people, technology, process, and policy. There you see why EHRs by themselves cannot create a learning health system. And this socio-technical infrastructure can support all of these cycles because even though they're addressing different health problems, they're all doing the same thing. They're all doing the blue to green to blue to red thing. And the commonality of the process, kind of like everybody wanting to get across the river, creates the potential for a set of services in an infrastructure to comprehensively support these cycles. So what does that infrastructure look like? Use your imagination. You're sitting on top of this tornado and looking down. And what you might see is an infrastructure that has 10 socio-technical services that are arrayed according to the piece of the improvement cycle that they support. And the services provide a bunch of different things. I won't dwell on these in detail, ranging from group processes to validated instruments to adopted standards, agreements and templates for data aggregation, technical platforms for doing analysis, knowledge synthesis methods, packaged knowledge synthesis methods for combining the external and internal evidence, consensus processes, so the community, when it gets to the top, can reach a settled consensus on what should be done, knowledge packaging methods to support interventions, technical and communication platforms to support dissemination of the innovation and the implementation science frameworks to help both implement and evaluate. And these are all generic services that could support the pursuit of any health problem just arrayed along on the periphery of the part of the improvement cycle that they represent. So here are my 4 top reasons why learning health systems can outperform other approaches. The first one is this idea has a spark to it. People like this idea. You describe it to them and it makes sense. I've never had anyone say to me, this isn't a good idea. They've said a lot of other things to me, but they haven't said that. And also it may have to do with the name of it, who can be against learning, who can be against health, and who can be against systems. So that's one reason, but if from a sales point of view, this is an appealing product. It has a holistic view on health, not just care. And if you just focus on care, you can't typically solve a wicked, challenging system health problem. If we had just focused in our out-of-hospital cardiac arrest on what happens when a patient who's clinically dead, in most cases, arrives at the ED, we're obviously not going to solve this problem. It's a system served by infrastructure. It's a system. A learning health system is a system. If you design it so that it has an infrastructure which makes it resilient, adaptive, and scalable. And finally, I didn't get into this in detail, but when you think about what a mature learning health system looks like, it's a transformation of an organization. It's an overhaul of the organization, not a cluster of patches. All right, AI and learning health systems. Took me a while, but we got there. So first, AI models, large and small. All AI is driven by a model, and these models come in many shapes and sizes, from very focused machine learning algorithms all the way to colossal large language models. But they're all trained for a purpose. They're all trained using appropriate data, and then they're validated in some way, and then deployed to execute whatever they're designed to execute: prediction, recommendation, diagnosis, identification, composing something, drawing something, whatever. All AI models are computable. The model is expressed, not in words, but as machine executable code. This is a mixed bag in that because they're expressed in code, we don't see the problem that has vexed the field for many, many years of taking guidelines and putting them into computable form, a problem that is still not really solved. But because they're expressed as code, they're opaque. And it's very hard to get these models to explain how they came to the conclusion they came to. Now, I'm going to focus here on small goal-directed models, smaller models, and we can discuss later if we have time on how larger models fit into this. So all models can be packaged as digital objects. What you see here is a model we've been using in my lab that we've developed over the last 7 years for a so-called compound digital object, which has 5 layers. In the deepest part of the model, the core of the model, of the package, is the actual code which executes the model. And then as you move to the periphery, you see the object contains the specifications for deploying the model, the specification of input and output to the object, metadata, which describes what the model does, where it came from, and finally, a model unique identifier. This packaging of models is essential. I don't know how many of you are familiar with the FAIR principles that have been mostly applied to data, that data should be findable, accessible, interoperable, and reusable. Well, the same applies to models. And if we are going to really realize the potential of AI, the models, large and small, must achieve these same FAIR criteria. If they don't, then we're never going to be able to share and improve models through collaboration. I think this is something that the value of which is self-evident. We really can't combine these models to make in any kind of elegant way to create synergies, or what computer scientists would call a composition, to create interventions that are more powerful and useful than what is possible if these models remain separate. And to my point, AI models, if they aren't packaged, can't be connected to learning health system infrastructure. There is a national, now multinational movement called Mobilizing Computable Biomedical Knowledge, which I invite you all to participate in. The goal of this is to make computable knowledge, which includes all AI applications, both fair and trusted. We call this FAIR-T. The now multinational movement has a North American chapter and a UK chapter, and I'm hoping that after the Medical Informatics in Europe meeting in May, we will have a continental Europe chapter, and soon thereafter a chapter in Australasia, and we'll approach a global MCBK movement. MCBK is doing a lot of things, and you can easily go to the MCBK website and find out about that. So why do AI and learning systems need each other? I think with these preliminaries, you probably can see some of where I'm headed with this. Let's come back to the gap at the top. It's a major challenge. This is where things often stall. And to see this, just think about the fact that human readable knowledge, for example, the recommendations of the US Preventive Services Task Force, have in actually impacting care. I mean, you think about a primary care practitioner who has 15 minutes to see a patient. There are something like 50 grade A and B recommendations. How in the world are we going to get these guidelines, if they're only in written form, to be used routinely and effectively, and most effectively, for patients, given the realities of healthcare delivery? Well, if you make these guidelines computable so that they are executed in code and couple them, and this is work that we've done, I'll say more about that in a moment, to AI-like precisionizing algorithms, which basically create a ranked recommended list based on a patient's characteristics of the preventive services that offer the most potential benefit to that person, then you can see how that computable model, which can consist of many, many of these objects, can give precision advice on the implementation side. And if the result of that advice is captured as data, that flows back into the system, and we have a greatly enhanced learning cycle using AI and using the structure of the improvement cycle. This is a way to do it that can work in the modern world, given the constraints that exist. I should say we're doing this now. My lab has developed the computable model, and this is now deployed in the Cleveland Clinic in their Epic system using their FHIR API, so that what is generated for primary care practitioners is this recommended list for that patient based on about 70 characteristics of that patient that is prioritized according to this algorithm. If there's more time, I'd be happy to talk about that. So AI, I've just talked about why the LHS needs AI to be able to basically deploy interventions at scale, and interventions at scale that, that use AI. Think of a metaphor here. What we've seen is a phenomenon that can be easily described with a metaphor to aviation. Any pilots here? Would anybody disagree with the statement that it's a whole lot easier to get a plane off the ground than it is to land it safely? I don't use your imagination. You don't have to be a pilot to realize this. You just need some flat land to get a plane off the ground. You need a lot more than that to land it safely. So we can think of proliferating AI models, which is happening right now. These models are proliferating at the speed of light as planes that were easy to get off the ground. It's much easier to make a model than it is to get that model implemented and actually making it useful. So all these models are now looking for a place to land. I would argue that LHS infrastructure, the kind of infrastructure that I presented, provides a haven for these models, a glide path, so to speak, to beat the metaphor to death, for these planes to land. So we got the plane easily taking off, the crowded skies with these models looking for a place to land, and all that instrumentation, metaphorically, that you see on the runway to help the plane land is the AI, is the analogous to the LHS infrastructure. So bringing this back to the point at hand, LHS infrastructure can routinize deployment of AI models. So let's begin with the fact that if you have this infrastructure, it's got the properties of infrastructure that it's persistent. London Tower Bridge isn't going anywhere. And once you've developed an LHS infrastructure, it's not going anywhere either. It's always there. And you have a packaged AI model or set of models packaged in the way I previously described. I'm not going to go over this in detail, but what you can do, if you stare at the slide for a while, is see that each of the layers of the packaged model for a digital object can be connected directly to a service in the LHS infrastructure. Now, if you stare at this slide and stare at what each service is, you'll see that these connections make sense. Not that it's trivial to land a model in an infrastructure any more than it's trivial to land an airplane, but it's possible and much safer to land an airplane on an instrumented runway than it is to try to implement an AI model in an environment that does not have the features of this infrastructure to connect to. Moreover, AI needs LHS because the improvement cycle itself provides a platform for improving the model. So in iteration one, when you try to do something like what we've done in the Cleveland Clinic, you do that with a particular iteration or version of the model. But in iterations 2 through n, however many cycles you go through, each time you go around and you take that feedback with the green arrow and enter that into the cycle, you get information that improves the model. So this landing field, this safe haven that the LHS infrastructure provides is a key to not only landing the model so it can work in practice, but also to improving it over time. So coming to a close, you can think now of an AI-enabled infrastructure for precision health as an example, and this is very similar to what we've done with the Preventive Services Task Force recommendation. If you start with the shared infrastructure and you're running these improvement cycles, you have people who can benefit. You've got your AI model that is driving the intervention that is expressed in code because it's an AI model that's being implemented. You have the model creating a precision intervention for each person and the capability of delivering this intervention at scale. You have the capability to learn from the intervention experience with the feedback. And as I said, that not only makes the intervention work, but it also creates a platform for improving the model. Closing with our Heart Safe Home scenario, just to show that this can work in many, many domains, you have the improvement cycle nested into the infrastructure. In this case, the target of the intervention is not people directly, but rather homes that are going to implement this plan. You have what we have not developed yet, that is a model in this case that can create a precision heart-safe home plan for each household. These plans ideally will not be one size fits all. You have the capability of delivering these plans in the future through a mobile phone app and the capability to improve the model from the reports of what happens if an arrest occurs in that home. So this AI-enabled LHS through these examples, I hope give you a picture of what may be possible really using ideas and technology that we have at our disposal today. So closing, a few points. Let's keep things in perspective, learning from that David Blumenthal ONC EHR experience. Let's view AI as a means and learning health systems as an end. Don't invert them. I think our society has a large component believing that AI is an end in itself and it's going to save us from every ill known to person kind. I don't think anybody in this room believes that. I mentioned that contemporary AI is a game changer, but it's still a means and not an end. And AI and LHS need each other for each one to realize its full potential. The learning health system remains the big end goal and reminding us that we're all here to make people healthier. Thank you very much. Wait, I thought he was disqualified. He promised.
Yeah. Not disqualified, just old. First of all, thanks, Chuck, for coming here. You don't realize Chuck is an icon in the field of biomedical informatics. He's one of the first generation of people who established the field. And if there are very few of those, Tom McDonald was the one, he is one. There are very few of them, and thanks for coming here and sharing.
Well, you're one too, Bill. So.
No, I'm the second generation. I was Clem's fellow. I want to talk about this thing in the infrastructure down here because there's a key piece of that is implied. I think it needs to be explicit, and that is leadership. That should go into one, organize, start, maintain, support learning health systems. But if you don't have a leader who wants it to happen, it's not going to happen. If you don't have people who are engaged, who can make it happen within the health system, then it's not going to happen. And I think that's the missing key. Now, an example is Eskenazi Health over here. It is a learning health system. And one of the reasons is that one of our former fellows, who was a successful health services researcher, has been the CEO for 20 years. Now, and she's made it into a learning health system. And one of the ways she did that is she hired away the director of our Center for Aging Research to be her chief research officer. And they keep making it, they make it happen. They fund it. They make sure that what they learn is incorporated into the system, and they facilitate that. And I think that's a key missing piece, is that the leader's got to want it. You can't force it on them, but it's going to cost something. What they have to realize is that it pays out in the end. A good example is a study was done here called the GRACE study, the study of a disciplinary intervention for frail community living elders to keep them out of the emergency room in the hospital and nursing home, et cetera. And it was successful, and it showed that in the second and third years, it actually saved money for the health system, which happened to be Eskenazi, which is mostly globally capitated care. So if you keep empty beds are good for that hospital. When they went to Lisa Harris, who's the CEO, said, we want to do a second study. Just stop. Don't study it anymore. We're buying it. We're going to implement it now. We're going to put it. We're going to do this for all of our elders, and they did that. But it took that kind of leadership and vision to say that this is us. And I think that part of this has to go in training of CEOs of hospitals and just built from the top down as well as the bottom up.
Thank you.
That wasn't a question, but.
We have a question from the online community. This is from Paul Dexter. Can you think of any healthcare institutions that have a very robust LHS infrastructure? What makes them different? Thanks.
So the first point I want to make, and I could have mentioned it when I showed the slide, is that if you look at a well-developed academic health system and you go service by service in those 10 services, all the resources are there. All the people are there to provide those services. This goes back to Bill's point. What is necessary, the magic ingredient that's necessary, the abracadabra, is to get them to function together and recognize that one of their roles, the people who provide the data, the people who provide the policies, that their role is to support these improvement cycles. So it's a connect the dots activity that has to be done, not just connecting the services to the improvement processes, but also connecting those services together around the cycle. So I could name just about any academic health system, and there's tremendous interest now in the CTSA community because the health systems with clinical translational science awards, by and large, know that they have that infrastructure, and it's been developed in large part, or to a significant degree, through those awards through the CTSA program. So yeah, I think, yeah, you can name any of the large medical centers, academic health centers, and say they have the ingredients of these in place. Certainly the University of Michigan does, and we've been working for almost 10 years to help make that into a functioning infrastructure. And we've done that in a variety of ways. So that's my response to that question.
I'm curious, as I look at the picture in the corner, the lower right corner here, I think one of the things that struck me when you were talking about delivering that information to the clinician is the volume of information that may get delivered to a clinician and the reliance on that individual clinician to translate that information into some action. And I'm curious because I feel like that's another place where there is an actual gap because you're reliant on a lot of preparation and training and willingness and engagement and also agreement with what's being provided, the clinical judgment that accompanies that. And I'm curious about your thoughts on that. And then I also was curious about your heart to home, heart safe home,
yeah.
Model as well, because there seems to be a similar kind of gap in that, okay, you have AI that can create a plan that go to your smartphone, but then somebody has to remember to pull up the smartphone when a family member is having a medical crisis and hit a button to figure out what they're supposed to do, right? And so there are these kind of challenges that we have around how we pull people into these systems. And I'm just curious about your thoughts about that.
Yeah, so thank you for those two questions. Question one, this is going to be an incomplete answer to your question, but the recipient of that advice or whatever comes out of the process is any human with a brain. It may be a practitioner, it may be a family member, it may be the patient themselves. So I use that figure to represent a human capable of carrying out a cognitive process. And the engineering of that, of course, will depend on the kind of intervention it is. And what we've done with the Preventive Services Task Force is to engineer the intervention so to recognize the time constraints. And what happens in Cleveland Clinic now, and this is taking 2 to 2.5 minutes of the interaction between the PCP and the patient, is that they see a dashboard. And it's a very elegant dashboard, which comes up on the Epic system, and the practitioner and the patient sit there and look at this together and reach a decision on how to do it. Now, the implementation details are critical and will vary from intervention to intervention, but I didn't mean to that brain to mean a particular type of person with a brain. In regard to the out-of-hospital cardiac arrest, I got so caught up in my answer. You need to repeat the question. Oh, yeah, thank you. I was just in a discussion about that yesterday, and it may be that what is the personalized or customized plan, it gets printed out and mailed somehow to the household, and they're told to put it up on the refrigerator, and that's where fire safe plans are. So yeah, and I think we're doing a lot of thinking about how this would be implemented, and in the event, in the moment, doing it through a smartphone may not be the best way to do it. You just put it on the refrigerator, do this, and then do that.
I have one more comment from online. It's from Nina Johnson. Great point. Leadership needs to be committed to this as a continuous quality improvement process.
So agreement with Bill, and I'm not disagreeing with that either, except to say that in our institution, our top leadership was skeptical. And but fortunately, we had a department, which is a persistent presence that was created with this mission, both to be a basic science department and to support implementation. And over time, we won the dean over. So I'm not sure this has to start with a top executive waving the learning health system flag and saying, follow me, follow me. We did it without that kind of support.
I just want to make the comment that if you ask the question about example of a learning health system, the VA is a good example of a learning health system, the largest health system in the country, 55 hospitals and millions of patients. They have their own health systems research organization that they rely on to help improve their process, and has been by external evaluators, actually from Great Britain, shows us the highest quality health system in the country, and that's one reason why. And sadly, it's being dismantled now. The research program of the VA is being dismantled, which is just shooting yourself in the head, not the foot.
Yeah.
I think we're at time. Thank you all so much for coming today. Thank you, Chuck, for being here. Great talk. Thank you.
Thank you.